goes if I can read it. Hi, it's going to be a challenge, greater and greater challenge as the day goes on to say something that hasn't been said before, because I think that everything that everyone said was really important, and I agree with it all. So the NYU caregiver intervention was actually, from my perspective, interesting in that it was something that I found already being carried out at NYU by clinicians before I got there. And as an epidemiologist, I was able to get funding to study it and find out whether it was better than usual care. And we were lucky enough in that funding environment to actually have more than 20 years of funding, so that we have very long-term outcomes. The intervention, I conceptualize it differently depending on the context, but it's basically got periodic comprehensive assessments of the caregiver and the person with dementia's needs, individual counseling, a very big emphasis on family counseling and ongoing counseling and support for as long as the person the caregiver needs it, even through the nursing home placement and death of the person with dementia. And there were, over the many years in which I was privileged to have funding from the NIH, many findings that we were able to demonstrate. Most immediately, we improved the social support for the person, for the primary caregiver, who in this original study was a spouse or partner of the person with dementia. That in turn, and then we also demonstrated a very short as well as long-term effect on the caregiver's reaction to problem behaviors, on reducing symptoms of depression compared to the usual care control group, improving the self-rated health of the caregiver and reducing the number of illnesses reported. And the thing that was that caught the attention of a lot of funders was that we were able to demonstrate that there was a difference in time to nursing home placement of about 1.5 years compared to the usual care control group. And all of these changes were really mediated by the change in social support that the caregiver experienced as a result of the intervention. So, no, which do I? Yeah. So, with all of this evidence and the new funding possibilities for translations, we were able to bring the NYU caregiver intervention to community settings. And in the 6 sites supported by the Administration on Aging, as well as the Rosalynn Carter administration and other funding sources, we've now had more than 600 caregivers enrolled in community settings. And so I've become very aware of the challenges that this has created. One of them is staff training challenges, which I mentioned earlier, and we have a lot of on-the-ground experience, and because up until now we've been doing the training in person. So one of the more senior clinicians and I go to every setting and do an in-person training of about 2 days, and then we ask the sites to follow up with regular meetings with us on the telephone, and also we offer them, it's sort of the style of the NYU caregiver intervention. There's in-person, then there's long-term follow-up, and then there's ad hoc counseling. We offer them the possibility of any counselor of calling us or emailing us at any time for consultation. So what we found on the ground was very different from what we experienced doing the randomized control trial at the university, where everyone was trained by each other and worked together all the time. And among the problems that we had was that it was difficult to explain all the components of the intervention and the reason for each, especially assessment. So the clinicians really, no matter how short we make the assessment, they want it shorter. So the assessment in the original study was intended to serve the purpose of providing data for me to analyze. But there was another purpose that we discovered as we were doing the assessment, was that it provided data for the clinicians to tailor the intervention to the needs of each person. And the clinicians really needed to understand that this was an opportunity, and that caregivers in general, what they told us in the original study was that that they welcomed the chance to actually think about what was happening to them and what some of their issues were, that the assessment sort of prodded them into thinking about. So another issue that we found was that the staff in the clinical settings without clinical experience had a great deal of difficulty implementing the intervention. And I have to say that when I started, I was so eager to give everybody the opportunity to have this intervention, that if someone said they wanted to implement it, I said, oh, good, thank you, let's get going. And I think what we've learned through time is that we have to be more selective about the clinicians, that they really have to have some clinical experience and understanding in order to do an intervention like this. I think it's another problem that we found with the training is that it was hard to schedule ongoing regular clinical staff meetings because everybody has different schedules, and to have them all come together at the same time, even on the phone, was difficult. And then lastly, we found that, and this was a real problem as we were doing the in-person training, was that we went to Florida, we trained 6 people, 3 people found new jobs, and they wanted us to come back and do it again. And so maintaining a trained staff is very difficult. In terms of recruitment, the recruitment challenges, some of them I think are very general and would apply to anyone, but I think one of the main ones that I keep seeing is the cultural values, and this is a general one for all of these kinds of interventions. I personally, if I had a spouse with dementia, would want a pill to give him to make him better. I wouldn't be, it's a hard sell to sell people the idea that what's really good for them, that's got the best evidence base at this point, is the interventions that we're talking about here that have nothing to do with pharmacology. We don't have a good marketing, we don't have drug company marketing budgets behind us, and so, so to convey the truth about how important these things are, I think is very difficult. And the culture that we live in, it's the culture that the physicians have. They want to prescribe medicine. It's the culture that the families have. They want medicine for their loved ones. It's sort of general culture. So that I think requires a lot of education. Also, I think stigma and the reluctance to seek or give a diagnosis is a huge impediment to all of our interventions being used. So if as soon as we got into the community, we discovered that most people don't have a diagnosis of dementia, even though they have symptoms. And someone in Minnesota called me very early and said, we have caregivers coming to our caregiver programs, and we want to have a chance to have this intervention, but their doctor won't give them a diagnosis. If the caregiver says, my husband has dementia, can we include them? And this was not one of our original eligibility criteria, but I think it's a really important consideration. And now that we're working with an insurance company on a pilot study, they actually combed their records for diagnoses of dementia, and then called me up and said, what's the prevalence of dementia in people over 65? Because we're getting less than 8% in our records. And so then they decided they would take anyone who had a prescription for a cholinesterase inhibitor and send a letter to all those people, most of whom had never been actually told they had a diagnosis of dementia. So they're taking this drug. It's supposed to make them feel better. They don't quite know why. I think that another issue, which is sort of related to the cultural issues, is the lack of awareness of the availability of these kinds of services and the value of them. I think that another problem is that many caregivers say, oh, I'd love to do this, but I haven't got the time. I'm so burdened. I'm so busy. I really can't do this. And also caregivers are not used to seeking, many of them are not used to seeking services for themselves. I think we see a very select group of caregivers, the ones who are help seekers, but there may be people out there doing the same, shouldering the same burdens, who would never think that they should be seeking help and don't even believe it when they're told they should. So another problem that is unique to our intervention and is sort of a catch-22 is the caregivers who so badly need the help and support from their family members don't want to involve their family members. That's why part of why they have a problem is that they think they can do it all themselves, particularly older women who spouse caregivers. They don't want to bother their children. They have their own lives to lead. And so just the reason why they benefit from the intervention is the reason why they don't necessarily want to participate. And also, as I sort of alluded to earlier, eligibility criteria are hard to maintain in community settings. For me as a researcher, there are a lot of challenges, but and one of them is something that Laura used to talk a lot about, is how do you determine whether fidelity to the original intervention is being maintained? And you know, I was listening this morning to the earlier sessions. People were talking about the fact that as they do the intervention, they get better at it. So is fidelity necessarily, to what extent is fidelity the ultimate criterion? If you can do it better and be less faithful, is that bad? and also as a researcher, I'm used to doing randomized controlled trials, and I can say the treatment group did this, the placebo group, or the usual care group did that, and this is how different they were after X amount of months or years. But so now in the communities, people say, well, how do we know that we're effective? And that's kind of an open question when there is no control group. I mean, I have some ideas about how we might start to measure that, but it's not the same way that we do in randomized controlled trials. But I nevertheless think it's crucial, if we want to make these interventions widespread, that we figure out ways to measure. And with the same insurance company, I sold the idea to them. I said, look, if you do this study, you won't even have to have a real control group. You can have a database control group, and we can look and see whether these interventions, mine in particular, but have an effect that you can measure in insurance claims in some way. But I don't think we can just say, well, it's a wonderful thing, and so we should give it to everybody and hope that they think it's effective. In terms of the challenges that I've already had to try to respond to, one of the ways we're responding to the challenge about training is that we're developing web-based training now that will include certification of staff and licensing of agencies. And it's going to include an interactive supervised support. In order to get the credential and maintain your credentials, you're going to have to not only take the training, but you're going to have to interact in peer supervision, expert supervision, and present a minimum number of cases. So we're hoping that will stop us from traveling to places we don't want to go, although I still wouldn't mind getting invited to places that I do want to go. Nevertheless, you know, if they do it in Paris, I want them to invite me. But the retraining of staff will not be an issue anymore, because they'll be able to get trained when they want, where they want, and as individuals rather than in large groups. We've had to broaden the eligibility criteria for the intervention, so we can't say you have to have a diagnosis of dementia, because a lot of people don't. And the communities are having to modify the intervention. We had to shorten the assessment. I got a lot of help and pressure from the Administration on Aging to do that. We shortened it somewhat. We relaxed the time frame for the components. So originally we said you had to have 6 sessions of individual and family counseling within 4 months, and that isn't necessarily realistic for families and communities, particularly when half the family goes south for the winter or north for the summer or whatever. So we've also sometimes had additional individual sessions to prepare the spouse caregiver to involve the family. And we also have reluctantly allowed family sessions with members on the phone, because one of the other problems that we've seen a lot is that family members don't necessarily live near enough to each other to meet on a regular basis. And we actually are hopefully going to be I think we have funding I hope we have funding to develop web-enabled counseling so that people can actually, with the newer technologies, do this kind of family meeting where the family is not necessarily physically in the same space or even in the same space as the counselor. Thanks.
Okay, and our next speaker is Dr. Linda Eastman, who's going to talk to us about the Georgia translations of 2 interventions. Here.